First of all, I want to thank all of you who are here today, who came to hear about newborn screening. I know all of you have competing priorities, so it's very meaningful to me that you're here. And to the rest of us, also thank you to Every Life for inviting me to speak and for all the work that the Rare Disease Caucus does. As from the introduction you heard, my name is Erica Barnes. I'm actually the Executive Director of the Minnesota Rare Disease Advisory Council. We're an executive branch state agency in the state of Minnesota. And I'm also the mom of Chloe, who was diagnosed with and passed away from a rare disease in 2010. I really want to, for my portion of the presentation, I really want to ground the entire rest of this session in the patient experience so that hopefully as you hear from these amazing experts who are going to talk to you about all of the positive policy we can make, it's really grounded in how meaningful this will be to the rare disease community. So I'll tell you a little bit about my journey, and then I'll tell you how that's very typical of the rare disease community. So my first kind of exposure to newborn screening was accidental and a little bit indirect. So after my daughter passed away in 2010, I was really trying to find ways to process the journey I had taken and process the grief. And so I was reading a lot of memoirs, learning, trying to learn from other people who had had experiences in either losing child or had a child with a disability, excuse me. And one of the books I read was by Pearl Buck, and I know most of us know Pearl Buck because of the work she's written about China, and she's a famous literary figure. She also had a child with a disability, and she wrote a memoir. It's very poignant and very personal. So I read this shortly after Chloe passed away, and it was very meaningful. It's also, as an aside, an interesting read just to see how far we have come with disability rights and incorporating people with disabilities into our community. But what I didn't know about Carol Buck, she actually had PKU. Carol Buck she lived to be 72, but unfortunately she had significant cognitive impairments. She wasn't able to live independently. And so the disorder that she had was PKU, which also happens to be, I believe, the first disease that was ever screened for on newborn screening. So in 1960, Dr. Robert Guthrie developed a blood test to detect PKU. And by 1966, every state in the United States had mandatory screening. So every child that was born in U.S. hospitals is screened for PKU. Right now, fast forward to today, if PKU is detected early and a child is managed, that child's development will be typical to their peers. So to go from 1950, where PKU would cause, untold cognitive impairment, to the community basically being able to function like their age-matched peers is amazing, and it's really what I'd like to call a happy ending for a patient community. So newborn screening is an incredibly effective program. We should be very proud. There are actually 37 diseases that are on the panel. But now I want to pivot a little bit to my own story and my community's story. And what I would say is that Chloe's story and the story of my patient community is a happy ending in waiting. And I think the best way to help you understand how meaningful newborn screening is to the metachromatic leukodystrophy community and to the rare disease community is to tell you what the journey looks like in the absence of newborn screening. So I'm going to kind of trace out for you what I went through and what is very typical for people with rare diseases. So my daughter Chloe was born in 2010. She was our second child, and she was born with a clean bill of health. She was full term, happy, healthy, nothing picked up on the newborn screen, and we thought everything was fine. We were your typical, young professional family, careers, and we thought our future was bright ahead of us. And at about 14 months, I started to notice some concerning signs and symptoms with Chloe, and I'm a speech pathologist by training. And so I was picking up on some subtle things that were a real concern to me. And so I started to ask questions of the medical community, and this is really where, sadly, everything sort of starts to get my experience is all too common in the rare disease space. So I started talking to a pediatrician, raising concerns, and the first typical thing that happens, which is what happened to me, was I didn't really feel believed. So the pediatrician had never seen anything like what I was describing, and so the relationship with the medical community really broke down. And then the second thing that happened was he prescribed ineffective treatments. So I was telling him, I think my daughter has some neurological issues. I would really like an MRI. And he said, nope, we're going to go ahead and do physical therapy and occupational therapy. And if any of you are familiar with neurodegenerative diseases, that's actually the worst thing you can do because it exacerbates the signs and symptoms. So she had that ineffective treatment for a while, and then I ended up firing that pediatrician and finding a new doctor. Fortunately, he was amazing. He ordered the MRI, and sure enough, she had demyelination in her brain. And then that's when all of the numerous visits to specialists began. So specialist after specialist, trying to figure out what exactly is causing this demyelination in my daughter's brain. Eventually, we were referred to the Mayo Clinic, and at 28 months, she was diagnosed with metachromatic leukodystrophy. Another feature that happens is within that time, because I wasn't getting answers from the medical community, I was doing a lot of my own research, and I actually came across metachromatic leukodystrophy on the internet at 3 a.m. And I think there's so many things as a society we can disagree on, but I think the one thing we can all agree on is that no mother should find a fatal degenerative disease that her child has on the internet at 3 a.m. That is not good medicine. And so, but that was my experience. So after she was diagnosed, she received a bone marrow transplant at the Mayo Clinic, and she passed away at 28 months. I think just from the story that I told you, you can probably infer some of the reasons that newborn screening would be beneficial to the metachromatic leukodystrophy community, to the leukodystrophy community, and many, many rare diseases. As Dwayne said, there's 10,000, and many of them have some of the features that metachromatic leukodystrophy does. But I want to just specifically call out a few of the reasons that newborn screening is particularly vital to the rare disease community. And the first one is it's really sometimes the only and definitely the best avenue to a timely diagnosis. So average time to diagnosis for a rare disease is 7 to 8 years for a patient. And there's a myriad of reasons, but probably the main one is few providers have familiarity with the symptoms of rare diseases to be able to diagnose based on symptoms. So having newborn screening reduces that diagnostic odyssey. If you haven't heard that term, it's what we use because that long time to diagnosis is such a salient feature of our community. So being able to reduce that diagnostic odyssey. In addition, pre-symptomatic diagnosis is essential to be eligible for some treatments. So there is now a gene therapy in metachromatic leukodystrophy, but in order to be eligible for that treatment and for that treatment to work, children have to be pre-symptomatic. So if I could take a moment to just really lay out the cruel irony and paradox here. So currently, in order to diagnose a child with metachromatic leukodystrophy, you have to wait till there are symptoms. In order to be able to give a treatment that would be beneficial, you have to administer it before symptom onset. So it's a dilemma that our traditional diagnostic pathways cannot solve. The next reason that newborn screening is particularly vital is being able to have early family support. So again, reducing the family's isolation and trauma from the diagnostic odyssey. It's probably obvious to you, but it was very traumatic for me to go through this diagnostic experience. Actually, the initial pediatrician lives in my neighborhood, and I've seen him a couple times, and I just have to walk away because it was so traumatic. Not entirely his fault, but there's just a lot of trauma associated with that journey. It also allows for the formation of a functioning patient community. So getting that early diagnosis, connecting with the community, and then working together to accelerate research and make change is so vital. And it's very difficult if you go for years and years without a diagnosis to connect. And then it allows for effective disease management. Again, if you are waiting for a diagnosis, if you don't have a diagnosis, the disease can really just exacerbate. You can have seizures, you can be going into the ER all the time. So knowing what the diagnosis is allows the medical community to manage those symptoms, which leads to better outcomes. So lots of reasons that it's particularly important. And the last thing that I want to say, and it's, if you don't take anything else away about my patient community and some of the other rare diseases, is that newborn screening solves for this very cruel reality of some of these aggressive diseases in the rare disease space. So newborn screening is the only diagnostic pathway in my community that would prevent one child being saved and one child being treated through the sacrifice of a sibling. So the person that you have on the screen on the far left is Amy Price and Giovanni Price. She's a good friend of mine. Amy has 5 children, and her oldest daughter, Liviana, was diagnosed with metachromatic leukodystrophy, very much the way that my daughter was. By the time that Liviana was diagnosed, she wasn't eligible for a treatment. But because these are genetic, often there can be more than one child with this disease. And so Giovanni was diagnosed with metachromatic leukodystrophy at 6 months. Giovanni was able to get a gene therapy. He is now 16, plays soccer, just an amazing kid. But he lives with the knowledge that his ability to receive a life-saving treatment came because of his sister's sacrifice. And so newborn screening is what solves that dilemma for our community. So I hope this helped sort of set the stage to help you understand. Newborn screening is a tremendously successful program for some patient communities, and we should be so proud that we have newborn screening in this country. But there's a lot of work to do, and we are now in a new frontier. Medicine is advancing very rapidly in the rare disease space. There are potential treatments on the horizon that were unheard of when my daughter was diagnosed 13 years ago. So it's very exciting, but there's a lot to do. And I'm going to pass it on to the experts to kind of walk you all through that policy. Thank you so much.